Good afternoon, everybody. Thank you so much for joining us for our third MDT Spotlight session. I am just going to grab my screen so that I can do a little bit of an introduction. Here we go. So yes, welcome. We're really delighted to be running the third of our MDT Spotlight sessions today, focusing on dietetics. Really pleased to have everybody here, sparing the time. It's going to be a really helpful session. I'm Chelsea Letts. I'm the Healthcare Engagement Programme Lead at Bliss. If you've been to any of our other events, you'll have seen me kind of around doing some of these sessions. But yeah, it's a real pleasure for me to be doing today's session too. I'm just going to ask our speakers to introduce themselves as well. So Mo, could I ask you to say hello?
Sure. My name is Maureen Mustafa, or you can call me Mo. I'm the lead dietitian for the London Neonatal Network. I work full-time for the network, and I also sit on the executive committee for BAPM, which is the British Association of Perinatal Medicine.
Lovely, thank you so much. And Layla.
Hi, my name is Layla Miramadi, and I'm a neonatal dietitian. I work in Queen's Hospital in Romford, and I'm working with Mo now today to do this webinar.
Thank you both so much for your time. I think we're really looking forward to today's session and kind of exploring dietetics a little bit more detail, which is great. Plan for today's session, we are going to keep to an hour like we have been for the rest of these sessions, and it will be recorded, so we'll be able to share this with you afterwards as well, and in case you missed it and watching back, welcome. We have a parent story to share with you initially, which I think will be just really helpful, kind of context setting, a little bit more about the experience of a parent working with the dietetics team on a neonatal unit, and then we'll go into a few kind of questions to kind of explore that and unpick some of the themes that come out of that a little bit more, and then hopefully we'll have some time at the end for some questions, but please do use the Q&A functionality that we have on this kind of team session today to ask any questions that you have. We'll keep an eye on that and try and incorporate those into the session. We have tried to make sure that any questions that were asked during the registration form process have been kind of incorporated into this already, but please do kind of prompt us and ask any questions that you have for that. If you have any technical issues or questions for the Bliss team, do pop them in the chat as well. We've got one of those functions too, and we'll try and come back to you to kind of support with that. But that is the plan for the next hour, and the reason we're doing these sessions is really to kind of highlight how important the roles of kind of allied healthcare professionals, psychology and pharmacy, and the wider MDT are to lots of different elements of the neonatal experience. So really trying to kind of increase awareness and knowledge of, particularly today, dietetics kind of within neonatal care, and to empower you as healthcare professionals to really support integrating dietitians into the wider neonatal team. We know that the provision of service is different in lots of different places, but we really want to kind of, as I mentioned, highlight how important these roles are to the delivery of family integrated care for every baby on a neonatal unit. And as mentioned, there's some challenges around kind of inequities of care because of the difference in service delivery. And I think it's really important that we highlight that will impact on how kind of parents feel like partners in their baby's care. But there are lots of really positive things happening in the increase of these roles kind of around the UK is definitely something that we can celebrate. So that's what we are hoping to get out of today's session. So I'll just stop sharing my slides, and I think without further ado, I'm going to go into sharing the parent experience. This is Bonnie. She introduced herself, so I won't kind of take up too much time doing that. But I think, she gives a really helpful overview and insight into her experience with her baby on a neonatal unit and her involvement with the dietetics specialism particularly. So hopefully a really useful start to the session. So I'll just get that up now. Okay, over to Bonnie.
Hi, my name is Bonnie. I'm 37 years old, a mom of two beautiful children, one being 7 years, a boy, and the last one being 15 months, but 11 months corrected. a little girl born only 700 grams at 25 weeks, and we spent about 157 days in total in a hospital setting in Naiko. So in this video, I'm just going to share my experience with the dietitian within the NICO setting and also after discharge. I could go on and on explaining how grateful I am about the experience we had with the dietitian. So I've written down the main points I want to share so they can help any other parent who could be in a similar position like what I experienced. So I'll just start off by thanking all the multidisciplinary team members from domestic workers, receptionists, nurses, doctors, physio, salt therapists, and the dietitians, because without them, our baby would not be 15 months in this world. So but on this video, I'm just going to share my experience of having a dietitian for my baby. So the information you receive when you have a very preterm baby is absolutely overwhelming. Your biggest worry is are they going to be able to breathe on their own? In my case, my baby was ventilated for well more than 3 months. She couldn't breathe on their own. So the next question was, how is she going to grow? How are we going to make sure she's feeding? So the dietitians came to see us on the very first day we went into a NICU unit. They explained to us parental feeding and NG feeding, and we used to feed the baby using a syringe, and she did put on some weight, but unfortunately she still was not meeting her growth points. So they changed so much of her milk until she actually reached a standard preterm weight. Having a dietitian made it less worrisome. They reassured us there was hope, and they explained every stage that was happening and what we could expect, and probably when we should expect to be able to feed our baby using breast or buttermilk. But because I was very much stressed, my milk supply vanished. I got treatment. The dietitian referred me to a milk lactation nurse, and the milk supply returned. However, it wasn't enough. So the next thing was they offered me donor milk. And I won't lie, I was very worried about using donor milk because I didn't know whether it will pass infections to my baby, yet she was already sick. But knowing that breast milk is the best for babies, I researched about it, and I even became more paranoid or anxious about it. But the dietitians came in to explain how the milk is from the milk from the donor is sourced or obtained, or how it's donated, and how it goes through screening until it becomes safe for newly born babies to consume. Time came for me to breastfeed my baby, and I was assisted with positioning the baby and breastfeeding with ease. It was as if I'd never breastfed a baby. I breastfed my first baby for 18 months, but with this baby, I was absolutely confused, unsure of how to breastfeed a baby. And the dietitian sat with me with the salt therapist and helped me to breastfeed my little one. And on every ward round, the dietitian was present and held the responsibility of changing my baby's feeding regime based on growth sprouts, your needs and nutritional needs. They explained all the micronutritional values to us, because it's a lot of medical terminology, how this is broken down, how this milk is broken down, what they're trying to avoid at this stage. So they explained during that time. I understood everything. I can't explain it right now because it's a phase that's passed. I'm focusing on something else, but they explained everything, and I was totally on board. And they gave me the power to choose what I thought was the best option after giving me all the information, which made me feel empowered or more of involved in my baby's care. Because while you're in NICU, it almost seems like you're giving away your baby to the multidisciplinary team. So this made me feel like I was actually mothering my own baby. Then discharge time came and I was very anxious and I was unsure. I knew I was going to lose all the support I was now used to, but it didn't end there. They planned the discharge planning together with us and they ordered the milk from the GP for us, showed me how to prepare it, showed me how to reorder the milk, and she would call me every week, I think for 3 weeks, and then later was 2 weeks for another maybe 3 weeks. And I actually had their contact details. And I remember one time I was worried my baby was having loose stool, and I called them directly. I got advice. They swapped my milk and cancelled the order from the GP and asked us to use a different SMA Gold Prem, which was a liquid version. And I also got winning advice from my dietitian. So I'm very grateful for the experience that we had, because among all the other worries we had, we assured at least we have people guiding us with the nutritional value whilst we're now at home. So I'd really like to say thank you for all the input, and if it wasn't for them, honestly, we don't know where our baby would be right now. Thank you.
Really moving to hear directly from a mother who has obviously experienced this and had the fantastic support of the team on the unit. I think really hit home for me when I was listening back to it, when she mentioned about how she really felt after having the support from the multidisciplinary team, and particularly the dietitians, how she really felt that she had the opportunity to mother and be the mother on the unit. So I don't know whether Layla and Mo, you wanted to come in and comment on anything that Bonnie mentioned in there before we go into questions. But I think a really helpful opening.
Well, to be honest, I'm speechless because it just makes me really like emotional, because I know this one very well. So I'm so glad that she had such a good experience. They went through very tough times. So we have to remember it's a very difficult situation when you have a baby in the unit. It's so scary. So I can understand how she feels. And I'm glad that we were able to help.
Absolutely. Yeah, I think it's just a big, massive thank you to Bonnie for sharing her story. I'm so grateful to have heard it. And, the words that stood out for me were she said, feeling reassured from the information she got, feeling empowered, which is essentially what we want when we're talking about family integrated care, empowered to parent their baby on the unit and then do it at home as well. Amazing. Really, really beautiful story.
Yeah, I totally agree. And I think really helpful opening with lots of the themes I think that will come over the next kind of 45 minutes or so will reflect some of that experience, I think. So the first question I wanted to put to you both is to kind of give us this fairly broad and open, but to give us a bit more of an understanding of the different roles that dietitians have on the neonatal unit, because we know that it's pretty broad on the unit and obviously beyond. We heard from Bonnie that it goes much further than that. So could you share with us a little bit more about the different roles in supporting babies and their families so that we get kind of a better picture of what the dietitian role is on the neonatal unit?
Sure. So Layla, you're going to go through your role first. I'll just share my screen.
Yeah, so I start
Thank you.
and then Mo will be following after my part. So basically, because I'm working on the unit on the like a floor, as we said, so I thought that it just give an idea that what we're doing on the unit when we are on the as a neonatal dietitian. So as we know, babies coming to the unit, they might be very unwell. They are born very premature. So the first thing is you might need to start some sort of parenteral nutrition. So we work closely with our pharmacists and medical team to make sure that that parenteral feeding plan meet all the requirements and make sure that the baby grows. And as the baby develop and we progress, we come to the time that we want to start some milk feeding, as we say. And Bonnie mentioned it, like we discussed different options that we have. If mom is able to produce some breast milk and this is the option that she wants to choose, then we support it, try to make sure that we start earlier on expressing the milk, how to do it, and go through that, make sure that we transition the baby from parenteral nutrition to milk feeding slowly, and then monitor the growth. If they are on the breast milk or donor milk, they might need some fortifier to help with the growth, or other supplements that we use to meet the baby's need. And then again, some of the babies, they might be too unwell or too young to have oral feed, so we have to use enteral feed to start with. Again, transitioning to that, how to support the parents, teach them. And again, I think Bonnie had a good point. We try to get them to be involved with the care of their baby as well, because it's quite scary to be on the unit and you feel I can't do anything. But if they learn how to do the feeding, they can help with that, they can get involved. We obviously personally attend the ward rounds, so we have these discussions every week as an MDT. When we have a speech language therapies, we have a OT and physios and the medical team to discuss how we can progress and how we can meet babies' goals and prepare them for home. And when we get closer to the discharge, then we can see if the baby needs to go home with further follow-ups, if they might need to go home with the tube feed for a longer period of time, or they might need to have continue with the fortifying the breast milk when they are home. So again, we are following that, provide the information to the parents, give them all the information so they know what their options they have, and we listen to them to see what preferences they have, what it works in real life for them when they go home. And we adjust an individual, we provide some like a specific plan for every baby to meet the individual's needs. And also obviously through that we are doing some training for the staffs and working with other health professionals. But I think Mo, you will gonna go through the all hard work you do behind the doors that not always might be seen, but it's very important.
Thank you, Layla. Yes, so because I work at network level, my role is slightly different. So we tend to talk about our network roles as having 4 key elements. The first one is growing the workforce. So like you mentioned, Chelsea, there are discrepancies and quite a bit of variation from one unit and one setting to another in terms of how much provision of AHPs and particularly dietitians there is. So we've been doing a lot of work in scoping what's already out there, what's available on the ground, and working with units and allied health professional teams to look at what they can do to increase their provision of dietetics to meet national standards as much as we can. And that involves, you know, a lot of communicating, education, making people aware of the gaps, engaging with stakeholders, and also where people are ready to supporting them with bids and business cases to drive and grow their workforce. We also want to support the workforce that's already existing, so we do that in a variety of ways. One of them is through clinical support. So this could be peer support or clinical supervision, and certainly in dietetics we have things happening at network level. So we have quarterly meetings in our network for the dietitians working in the units. We also have at a national level communities of practice where we work not just with unit dietitians in England, but also in the devolved nations to do peer support. I'm also available for clinical troubleshooting. So if a dietitian on the ground has a particular case they want to seek advice over, they can always reach out to me. So we definitely want to be supporting the staff that are already there. And we also do that through education and training. We want to make sure that the dietetic workforce is as skilled as it can be, using the best evidence base, and have easy opportunities to continuing professional development. So whether that's providing resources online, and I'll talk about some of those resources later on. We also do a lot of education and training with the rest of the MDT as well. So our other allied health professionals, doctors and nurses. We collaborate with family partners. So, for example, collaborating with you today, with Bliss, but also our parent advisory groups that we have within our networks and care coordinators. And then the other final key element is clinical governance. So we're quite heavily involved with this. Layla touched upon some of the things that happen on the unit, and some of those aspects, for example, take parental nutrition. Often we try as much as possible to standardise those elements of care. So we work either at network level or at unit level with producing guidelines to make sure that PN use is standardised. We may support with audits, quality improvement projects, and other policies and working groups.
Brilliant. Thank you both. Loads. I think it's always so helpful to hear more straight from you about exactly kind of what's included in all of that, because I think it's makes everything much more clear. The next question I have is actually a bit of a recurring theme from some of the sessions we've had already, which I think is really helpful because it kind of demonstrates that there's a real kind of clarity of thinking about universal, specialist and targeted support. So be love to hear from you about how you see that working as a framework within the kind of dietetic services, and kind of who can benefit from those different levels of care.
Absolutely. I'll just share my screen again. So yeah, you've people on the call might have seen a similar pyramid before. Our version is inverted because actually we strongly believe that it's the universal element first that families often experience before the one-to-one specialised care actually starts. Giving the example of parental nutrition, the dietitian isn't going to be necessarily there at the cot side when the baby is starting PN several hours after they've been born, but the work we do behind the scenes to, for example, make sure that the PN is standardised, making sure that the guidelines have been disseminated and educated to all team members. That's what's happening at a universal level, and that's how dietitians can and AHPs can impact the care of every single baby on the unit at a universal level without that one-to-one specialised care that Layla talked about. So yeah, universal is very much so that the care that impacts every single baby and every single family on the unit. Another really good example is early provision of colostrum and breast milk. There is this standard that a lot of units are striving for to get that golden milk colostrum to the baby within 6 hours after they're delivered. And when we think about that from a universal level, again, the dietitian wouldn't necessarily be talking to the mother antenatally or in those first very early hours after she's delivered her baby prematurely. It would probably most likely be maybe a midwife or a doctor talking to the mother. So then we are involved alongside the rest of the allied health professionals, for example, and also our psychological professionals in educating those members of staff in how to sensitively approach talking about early breast milk and colostrum provision to families. I think everyone is aware of how important and helpful breast milk is for these babies, but we also need to acknowledge how sensitive that topic is, particularly for families. It's not always easy for mothers to produce breast milk, and even Bonnie talked about that. She talked about how her supply ran out, and thankfully she got some support to bring the supply back, but it still wasn't enough. And what the last thing we want to do is negatively impact the experience that mothers have when they are trying to, or if, for example, they choose not to, we certainly don't want to ostracize them for not. So it's a very it needs to be approached in a very delicate and sensitive but encouraging way. Targeted is again about specific pathways and interventions for specific baby groups or for patient groups. So again, policies and guidelines around enteral feeding, parental nutrition, which babies require micronutrient supplementation and which ones don't. And yeah, Layla already explained very beautifully the specialised element.
Thank you. I think that's really helpful to give that kind of, again, picture of what that might look like on the ground. We did have a question about the early colostrum, so through the registration form. So I hope that answers your question, but please do pop any other questions that you might have around anything that we discuss in the Q&A, and we'll try and keep an eye on that as we go through. My next question is touching on something we've already kind of mentioned about, which is kind of family integrated care. We know that everybody's really striving towards this delivery of care, which is fantastic and definitely kind of where we want to be supportive of kind of doing that going forward. And I think building partnership with parents feels so integral to that. And I just wonder whether you can expand a little bit more on how the role, your role as dietitians really can support parents feeling like parents. We heard Bonnie kind of mention that in her video earlier. So I just wonder whether you'd be happy to expand on that a little bit and like how practically you're able to kind of really foster that culture on the unit.
Right. Okay. So I think Bonnie mentioned it very well, actually, because when you look, AHPs or dietitians, we spend a lot of time on the unit every week. Compared to if you think about doctors and nurses, they do rotations, they shift. So they rotate, they change. Every week we have a different consultant come to the unit, but we are there. We are always there on the ward rounds. They know us. So I think we have a very good opportunity to build a good relationship with the parents. And from my experience, I think sometimes we are become their voice sometimes, because sometimes parents don't feel confident or easy to speak their voice or raise their voice or concerns. But we are there. We spend a lot of time with them. Is it discussing the milk options, the choices that they have, what type of feeding we want to do, even just all try to get them to be more involved with the care of the baby. I think it is very scary when they come into the unit, see the baby is in the incubator with lots of things connected to the baby. They might not feel really comfortable even to carry the baby or hold the baby. So as the AHPs, not necessarily dietitian, but as AHPs, we can help them to become a part of the patient's journey, baby's journey. So like, is it skin to skin? Is the kangaroo care? We can spend a lot of time talking to them. And sometimes my experience was sometimes I'm going to see a mom and dad about something, and then we end up talking about something else because they just want to be heard. They want just to raise their concerns, or they want us to hear their wishes, what they want to do about the baby's care and things like that. So I think we are in a good position. Obviously, we have some barriers there because sometimes our shift work, our hours of work, it might not meet the same time that their parents can come to the unit. There are babies that sometimes I might never seen the parents because they can't come in the morning on the ward round or in the afternoon. So again, we still try to use other ways of contacting them, like phone calls, even video calls and things like that, that helps. We have our unit, there are lots of moms, parents coming that English is not their first language. So again, that's a big barrier, and it can be very scary when you start talking, and if they are talking about all medical conditions and they don't understand it. So we try to use interpreter. Again, it's been times that we went back because we thought that, okay, we need to spend more time, book an interpreter, sit down in a quiet room and have a chat and make sure that they understand what's happening. We understand what they want. So I think we are in a very good position to help to get them involved, support them, provide education. And if there is something that we can advocate for them to the other medical teams, like we are lucky, we have psychotherapists on the unit, and a lot of time we communicate with each other because she pick up something and she wants to let us know when we are talking to the parents to be aware of it, or we picked up something or mom said something, we talk about it to the psychotherapist, and maybe you need to support mom and see mom. And I think it works very well. I think the doctors are too busy, and because they keep changing, they might not be able to get that relationship as such that we can get.
Yeah, there definitely seems to be a real benefit to having that consistency and being able to build that relationship. And I think some of the things you were mentioning, Leila, really highlight kind of it's tackling those barriers and taking kind of each family in their situation, in their context, and individualizing the care for them and based on what they need in order to be able to be kind of partners in their baby's care. Does that sound fair? Is that feels like part of your role and what you try to do? Sounds almost like it's a natural
we
thing.
are there to take care of we are there to take care of the babies and the family. So it become part of your, if you're not a caring person, you are not going to be in this job. So part of it might be necessarily dietetic related, or I don't know, physio related, but we picked up on it and then we try to get help and support from appropriate people.
Yeah, definitely. I really hope that that's coming across as the theme of these sessions generally, because I think it really feels like that's a prominent learning to share, is that kind of how important, you as allied healthcare professionals and psychologists, like pharmacists, all together to kind of really provide that rounded care and support the family and obviously the baby as for what they need at that time, and really enabling that kind of for those best outcomes. So thank you for sharing a bit more about that. It's really helpful. I think kind of going alongside that and kind of building the relationships, a kind of really key part of that is communication. Communication comes up as quite a important theme in lots of different areas of our work. It's amazing how much that does come up, and it is a challenge sometimes to get that right. And it's obviously a really important part of your clinical roles to communicate with parents and carers about what's going on with their baby, and kind of engaging them and empowering them to be part of that. So as kind of experienced neonatal dietitians, what would you kind of want to share with the audience for your kind of top tips on communicating with families around this sort of work?
Yeah, that's a really good question. I think that and Leila kind of highlighted this earlier, that it's just to remember and always acknowledge that if your baby is admitted to a neonatal unit, it is a traumatic event. There's no way around it. We have to acknowledge that. We can't sugarcoat that it's going to be a traumatic experience for these families. And I've met neonatal parents where their children are much older now. They're in their teen years, but they still talk so vividly about their experiences on the neonatal unit like it was yesterday, because it is so traumatic. So I think keeping that in mind, that really can help remind us of how we communicate with families. And certainly for me, I think honesty and empathy are key, absolutely key. We have to meet families where they're at, and we can't dismiss or sugarcoat any of their experiences. And again, Leila talked about some of this already, but taking time out to make sure that families understand what's going on and including them in the decision making, listening to their concerns and worries. And like she said, because we are, as AHPs and dietitians, we are often that consistent face that the families get to know over the weeks and months that they spend on the unit, versus the doctors and nurses that change and rotate every day or every week. They really come to a place where they can trust us, and they build a really deep, meaningful relationship with us. So also, like Leila mentioned, trying to avoid as much jargon as possible. We do use a lot of technical language on the neonatal unit, but when families are present and when we are talking to families, we need to make sure that they understand what we're talking about. And also being patient and allowing families to digest information at their own pace, and giving them space and time to respond. And that might mean we need to recover certain topics more than once. Even Bonnie mentioned that herself, that when she arrived on the unit, the amount of information she received was so overwhelming. So we shouldn't be surprised if we do need to recover or redress any particular topics or areas with families, because, like I said, it's been traumatic. And you can imagine, if you've been through a traumatic experience, any information you receive at that time is kind of in one ear, out the other. So yeah, really being patient, honest, and empathetic, I think, is really important.
Thanks, Mo. Anything, Layla, you wanted to add to that? As Mo kind of
No,
covered
I think Mo
everything.
just covered everything. Yeah.
Perfect. Thank you. I think really helpful. It's always a useful reminder, I think, kind of when we're thinking about this more broadly, how important that is. So thank you. We've spoken a little bit about obviously time on the unit, and Layla kind of obviously really helpfully explained more about your experience. And I think Bonnie mentioned follow up, and I think we've briefly touched on it already, but I wonder whether you can share a little bit more about what that might look like, our kind of for the kind of longer term journey, and what that means for babies and families kind of months, years down the line, because we know the neonatal journey isn't just kind of on the unit, it's much longer than that experience. So I wonder if you'd be happy to share a bit more about kind of the role of dietitians within that too.
Yeah, but obviously what I say, it might be different to unit. So
Yeah,
I'm just saying based on what we are doing in our unit. So we are able to do some follow-ups for our patients, depends on their needs. If they are going home on home fortifying, then we are seeing them on a weekly basis in joint clinic with our community outreach nurses. We manage to have a very good relationship with them. So even if we are not physically able to attend the clinic, always have a good communication. They let us know what's happening, and then we can provide the support. But we do that. Or if you have for a short term, they go home, babies need a steel tube feed, we might be able to help them. We try to see them if need be, the ones that they need up to age of like 6 months or around the time that they start some solids, so that we can support some weaning advice with them. And then if after that they still need some support, then is the time that we refer them to the general dietitian, general pediatric dietitians, and they can be seen in clinic. But they always, when they go home, they have our contact numbers. They can always ring us. As Bonnie mentioned, that she rang us and then she needed support, we are there to help. And sometimes it's just a reassurance, and sometimes and we have to remember, if they have been on the unit for such a long time, is very suddenly you feel, after all of these monitors and all of these people that are looking after your baby, you are suddenly going home on your own with your baby. It can be really, really overwhelming and scary. So I think it's good that we can offer some of the support when they go home, and they know that they can easily contact us. That's what has been we were doing with our set of patients, but obviously every unit is different, depends on the staffing and level of the support they have.
Exactly. Yeah, that's really, yeah. Sorry, I was going to ask Mo whether you had any insights from kind of from your ODM role and thinking about that more broadly, because we know that that's not necessarily the case everywhere, and what that might look like in other areas.
Exactly. I mean, Layla gave a really good example of where there is really good support when babies go home, and it is a shame that it's not the same in every unit. There are some units where, because even inpatient provision for dietetics is not enough, that unfortunately they're not able to provide any kind of support. So really it might be only the babies with the biggest needs, for example, a baby may be going home with a feeding tube long term, that would get support in the community. And yes, so it does and it varies even with other professions, even with outreach services. Not every unit has outreach services at the moment. So it's definitely a big gap that we're aware of, and we're continuing to work with units and try and highlight, the risks around that, because these babies are still vulnerable when they go home in the early stages, where they're still developing those early feeding skills. And like Layla said, it can be quite daunting for families, and having that safety net is often just enough for them to feel more confident about going home. So yeah, but there is huge variation, unfortunately.
Yeah, and I think as I say, it's the reality of the situation at the moment. We know that there's lots of work ongoing to try and kind of really tackle that, which is great, because I think, yeah, it'd be amazing if we had every neonatal unit and every baby going home having the kind of amazing support that Layla mentioned. Brilliant. Thank you so much for kind of going into that little bit more detail. One of the questions that we had through from the registration form was around kind of sharing good examples from that you've heard or seen about kind of collaborative working between staff and wider MDT, and obviously particularly with yourselves. And I think that I think is a really helpful practical question. Some of the things that you've mentioned and touched on today definitely answer that question. I think the early colostrum particularly, but I wondered whether there was anything else on that you wanted to expand on, or any other particular bits. I know, Layla, you're obviously quite well kind of embedded in the unit, whether there's any kind of particular experiences that you can share about what really works well when an MDT is really working collaboratively, and how that can kind of support with best outcomes for the baby.
More, do you want to go, or do you want me to?
If you've got, do you want to go? That's fine.
Well, because I think we are lucky because we do ward rounds at the MDT, so there is a good opportunity. We can discuss every single baby on the ward round, and everyone can give their feedback or report back that how they feel about the baby's progress. And I have to say, I've learned a lot on the MDT ward rounds from our physio, our speech language therapist, and I think it's a very good way of doing things at least once a week, to do a ward round at the MDT if it's possible. And also, like what we have like some sort of AHP meeting that we meet, all the AHP meets, and then sometimes just to give support each other, and then how we can do the service better, or that's another way of helping our patients, because if we know better how to deal with the situations, we can help our parents and babies during their stay on the unit. I don't know what's Mo, you want?
Yeah, no, definitely. There's lots of great examples across the unit. You know, I talked a bit about guidelines, and I've seen that at unit level, and sometimes even at sector level, where multidisciplinary teams are coming together to write a clinical guideline or update a clinical guideline, like some of the ones I mentioned: parental nutrition, enteral feeding, developmental care. Our entire network is working in a multidisciplinary way to write developmental care guidelines. Another group that I started when I came into this post was a multidisciplinary nutrition nutrition group, which is for the entire network. And like I say, it's multidisciplinary, and we're working on different projects to standardize nutritional care across London. So we have in that group doctors, nurses, pharmacists, and dietitians, and we've already done quite a bit of work already, even working with families to co-produce parent information on parental nutrition and things like that. So there's it's wonderful to see, and especially as the workforce grows, more and more work comes together, because there's more opportunities with more people on the ground to collaborate and improve the care that we provide to babies and families.
Yeah, it's a really exciting time, I think, when roles are becoming really established and growing, as you say. There's much more opportunity to collaborate. So I hope that answers your question to whoever wanted to kind of hear a little bit more about that. Thank you very much for sharing. As I said, please do, if you've got any questions for Layla and Mo, please do pop them into the Q&A. I wonder, while we're waiting to see if there are any questions coming through, whether you are happy to share any kind of what might be next, if people are looking for kind of a bit more information after today's session, kind of think you've made them kind of get the dietetics bug and want to learn a little bit more. Like, is there more opportunity? What would you recommend? Is it reaching out to kind of the ODN leads? Yeah, just be helpful, I think, for people to know where to go next.
Yeah, sure. So I've got a few slides just for people who want to find out more about neonatal dietitians. We, as a group of network dietitians in England, we have a group called NatNeo-RD, and we also collaborate quite closely with our specialist interest group, which is part of our professional group, which is the BDA, the British Dietetic Association. And we have a set of pre-recorded webinars which explore the role of neonatal dietetics. It is certainly more geared towards dietitians maybe working in pediatrics or in the adult world who are interested in maybe specialising in this area, which is really exciting. So there's a QR code for anybody who might be interested in watching that. We also have worked with NHS England to develop, hopefully most people are already aware of e-learning for healthcare. It's free for all NHS staff, lots of virtual modules for people to work on. I would highly recommend for those who aren't very familiar with allied health professionals to go with the first module, which is an introduction to AHPs in neonatal care, and you'll get a really good explanation of all 4 disciplines. And then there's also a neonatal dietetics foundation level module as well on there. And then also just earlier this year, I wrote a paper with one of my colleagues, which talks about the evolving role of dietitians within neonatal units and beyond. And this is just, I guess, amalgamating the evidence base as to why dietitians are so important and integral to the wider MDT on neonatal units and beyond. So certainly anyone who is thinking about a business case or uplifting, this will be a really good resource to have a look at. And then finally, yes, these are the contacts of all of the network dietitians working in England. We do have 10 ODNs, but currently 2 of those ODNs, the positions for the dietitian is vacant, unfortunately. But for the other 8 ODNs, there are the names and the email addresses. So if you have any queries, do feel free to contact the lead dietitian for your network.
Yeah, that's really helpful, Mo. Thank you for running through all of that. We've had a question from Katie, who said, are the modules that you mentioned available for staff in NHS Scotland as well? So I think it was in NHS England.
Yes, unfortunately, it's NHS England. I believe there's like a nominal charge for people outside of NHS England to pay. I can't remember how much it is, but once you pay it, you have access to everything on e-learning for healthcare. So, and there are literally hundreds of modules on there. So from what I understand, it's incredibly good value for money in terms of CPD.
I have to say those modules are really good. We even started using the basic ones for our students that they spend some time with us in pediatric. It's a very good source of information. So I would encourage people to have a look at it.
Absolutely. Even, for example, when nurses are new to neonates and we're doing training within the network, we signpost them to those modules online as well.
Great. Thank you for clarifying that. We've had quite a long comment in the Q&A actually about an experience that I think it's Ella who has kind of raised on the neonatal unit, particularly around providing a baby with vegan milk. So I wondered whether she's put kind of the question at the end is kind of how would you support a mum who is kind of struggling? So she's struggling with her milk supply and she's struggling with kind of what she feels is appropriate to kind of feed her baby based on obviously her choices and her preferences. So I wonder whether you've experienced anything like that you could share a little bit more insight into, and whether there was any kind of way of working with the MDT to kind of help support that situation, because I can imagine that could be probably quite tricky.
Yeah, from my experience, because we had this cases before on our unit, unfortunately, as we know, there is no vegan suitable formula in the UK, and majority want to do the breastfeeding, provide their own milk. So previously what we did, we tried to speak to other infant feeding lead and then get as much as support as we can from mom to see if we can establish the breastfeeding. But I always, again, we are going back to be honest with our parents, and I always discuss that this is the situation we have. We are doing everything that we can to get the milk production started, but unfortunately, it's not much option in terms of the formula. And then we had in one case that unfortunately we had to go and start some sort of formula for the baby. And we used donor milk for a while as much as we could, but then we have a limitation at the length that we can use donor milk. And then the parents agreed that we can start some sort of formula for the baby, but it is a very tricky one because it's not much options. We don't have any options. If they are lucky and they can do the breastfeeding or they want to do the breastfeeding, that's fine. But that, as we said, it's not always suitable for everyone to do the breastfeeding for any reason. So this is a bit tricky, yeah, unfortunately. I don't know more if you know about any other solution that I would be happy to know as well.
Well, I was just going to say, even Bonnie kind of mentioned it in her story about how she was really apprehensive about using donor milk. And again, I think it comes back to taking that time to sit down with families, really being honest, being open and explaining, providing that education so that they can make a more informed choice as to why the baby may benefit from donor milk or another formula. The situation I often came across when I was clinical was babies who had some sort of medical condition and were requiring a specialist formula, and the family, for example, were Muslim and they wanted to ensure that the formula was halal. And in some cases, though, the specialist formula we were using to treat the medical condition was not a halal. And so again, it'd be sitting down with the family, explaining that it isn't halal, having a good knowledge base around people's religious beliefs and understanding that if they talk to, a senior person within their religion, for example, an imam, and having that understanding that when it's a life-threatening situation or a medical situation, that there is some exemption when certain products can be used if it's to treat a medical condition. So I think it goes back to patience, taking time out and really listening to the family's concerns and then providing them with the right information so that they can make an informed choice.
Yeah, thank you both. It is clearly can be very complicated, and as you said, I think we touched on before, quite an emotive element of the experience. So that importance of, as you've mentioned earlier, about how to communicate and really supporting and listening to that, and being really clear and honest and open about the limitations. Not that will necessarily solve all of the problems, but that sounds like a really helpful way to go. So thank you very much for sharing those insights. I hope that was helpful for Ella, who kind of asked the question, kind of how that might all work. We've had a question from Mary, just a technical one about, will this presentation be available after today? Yes, everything is being recorded and we'll send it across to you via email, but it will also be available on the Bliss website after today. So give us a day or so that we can get it up. But yes, it will be available so that you can get all of the links that have been shared and the details that have been shared by Mo and Layla too. A few thank yous coming through already, which is great. Haven't had anything else in terms of kind of any of those more technical questions. I don't know whether there was anything, Mo and Layla, that you wanted to make sure was mentioned today that we haven't quite got round to squeezing in so far. But otherwise, I think thank you very much for all of your insights. It's been really, really informative. I've learned loads. So thank you.
Thank you for having us.
Yeah, thank you for having us.
No, it's been a real pleasure. We're really grateful for your time and as I say, for kind of sharing your insights. So and a big thank you to Bonnie again for sharing that her story. I think it really helped shape a lot of what we were discussing, and a huge thank you to everyone who's come along today or is watching back. I really hope that you found this session beneficial. We are going to be sending across some the link for this recording, as well as a link to some feedback, which we'd love you to complete. We're obviously always looking at ways that we can kind of improve how we're supporting you through these events. So please do share and kind of any thoughts and insights with us, either via that form or you can drop me an email. And if you complete it and pop your email address in, then we'll send you a certificate for attending today. So it's a nice little bonus at the end. a quick plug for the fact that we've got other sessions. The 2 sessions that we've run already are available on the Bliss website, and we've also got another session taking place next week on the 4th of July with speech and language therapy, and then we have another 2 that will be planned for September, which will be occupational therapy and pharmacy. So we're not done yet. We're halfway through the 6th, and they've been brilliant so far. So I really hope that everyone who's joined in has really taken loads from that, because I think we certainly have. But please kind of watch back, use them in kind of opportunities for training. If you've got staff who aren't quite sure about the different roles on the unit, hopefully this gives a really helpful flavour and taste of kind of what the allied healthcare professions, the specialisms are trying to do and deliver on the units, as well as beyond that. So yeah, please do use them. They're there for that purpose. So we really hope that they continue to be useful after today. Brilliant. Lots of thank yous, which is great. And thank you everyone for coming. So I think that's it. We're very efficient with this session, but yeah, huge thank you, Layla and Mo. We're really grateful for your time and hope to see you at another session at some point soon.
Thank
Take
you.
care.
Thank you very much.
Bye, everyone.
Bye, everyone.